It's a pleasure to introduce Barry Laird. So Barry's an academic palliative care physician and a reader at the University of Edinburgh. And Barry has been involved. It's actually nice to see Barry back because Barry was involved really at the start of much of our mesothelioma planning. And Barry has continued to be involved mainly in this study, Systems 2, which we're going to hear all about. And as I say, it is an exciting topic because it's only the second time this has been presented and it's not published yet. So hand over to Barry.
Thanks, Kevin. It's nice to be back and back through West, where I'm from. So yeah, very much presenting this work on behalf of the team. Key people are Miranda Ashton and Anthony Chalmers, who've led a lot of this work. And it was presented just a few weeks ago at BTOG, so you're only the second time it's really been heard. And I'll start with a question. See how the older people are in the audience, or how well the slides comes up. Who knows what this building is? You can read it even. Do you remember it, Kevin? Do you remember this place? It's now demolished. No. This is Hunters. This is the old Marie Curie Hospice in Glasgow, Hunters Hill, which was a shiny new building. And it was here in 2005, in my second year of training in palliative medicine, that I think I first came across somebody with mesothelioma. Now that's not to say, in the years before I hadn't come across somebody with mesothelioma, but the patient I had in this case really made an impact on me. After doing palliative medicine for a couple of years, you feel you can manage quite a lot of things really well, particularly pain. We've got a lot of drugs in the toolbox for managing pain. But this chap I looked after here, who'd been a shipyard worker in Glasgow, had the most severe chest wall pain I'd ever seen. And we really struggled to get it under control. We didn't get it under control. And he sadly passed away without his pain being well controlled. And it always struck me that that type of pain and the other type of pain I think that I deal with that's quite tricky is sort of disseminated cancer in the pelvis, which causes sort of pelvic pain, are still the two most difficult types of cancer pain that I manage. And so that's when I first sort of really impacted on me, I guess. So fast forward here to 2012 actually, January 2012, and this is the check-in at Edinburgh Airport, and I'm going away lucky enough to go away skiing for a week in January, and I'm standing in the queue at Edinburgh, and I hear a voice behind me. Oh, hi Barry, how are you? And, it's Nick MacLeod. Nick MacLeod's an oncologist in Glasgow. At that point, he was an oncology trainee in the Beatson in Glasgow. And I was doing research at the point, I said, "What, you're going to do some research, Nick? It's important you're an oncologist, you do some research." And he said, "Well, I don't really fancy going to a lab. It's not really my thing." So as we flew in, by complete chance, he actually happened to be sitting in the seat behind me, all the way to Chambéry, which is the other picture on the screen. We discussed what he might do as a research project, and he was interested in radiotherapy. I was interested in pain, and I remembered this case, and I thought, is radiotherapy, is it of any use for people with mesothelioma and chest wall pain? And we discussed this, and we had this idea: could we do a small study to see if radiotherapy was actually useful for people with mesothelioma who had pain? And I put this quote up. It's a paraphrase of what Steve Jobs used to say. But ideas are quite fragile, and it takes a lot of time to take an idea, not get it thrown apart, pulled apart by people, and get funding. But we took this idea and we developed it, and after reviewing the literature, we realised that actually people were getting radiotherapy for mesothelioma pain And no one had really done any sort of detailed study to say, does this actually work? Does it not work? Does it cause harm? So, although I'm a little more of a team player on the Systems 2 trial, I led the Systems 1 trial with Nick. And this study was really simple. We did a single-arm trial, so that means we gave all the people in the trial the same thing. We gave them 20 grays of radiotherapy in 5 fractions. And we did this in 40 patients over 3 centres. Now, we did it over 3 centres. We recruited, I think, 36 of those patients from Glasgow, so it was really Glasgow heavy. And we took people who had a reasonably good performance score, so quite relatively good functioning, living well, and pain of greater than 4 out of 10 on a 0 to 10 pain scale. And we did the recruitment here. Now, the graphs here, the black here is a non-responder, and the greys are responder. And overall, we showed in this study, everyone got the same thing, that about half the people tended to respond quite well. About 40% of people tended to get a benefit from the radiotherapy. Now, there's 2 ways of looking at that. You can say, well, actually, 60% didn't get a benefit. But in terms of trials of drugs, if you've got a drug that helps about 1 in 2 people, that's actually pretty good. So we're quite encouraged by this. And the challenge with doing a study like this, which will be pertinent as I get on further on in my talk, is to limit the background noise. What you want when you're doing a clinical trial is to have nothing else affect the outcomes that you're examining other than the one thing that you're testing. And the challenge with doing a study like this, which is a pain trial, it's a trial of an analgesic, the analgesic in this case was radiotherapy, is that we want all the other analgesics to stay the same, so that we can see if it was our treatment that made the difference, or it was or not, or it was analgesia. So one of the key things we did in this trial is we tried to make sure everyone had really good, or as good as they could have, pain control before they went into the study. So Nick and I saw these patients together. So he saw them in an oncology hat, I saw them in a palliative medicine hat. So actually there was no real difference in the analgesic use. In other words, these patients who seemed to respond well, it wasn't due to the fact they had more drugs. So this was a small study, but I was quite proud of this actually, because this was the first in-house radiotherapy trial in the Beatson at the time for 25 years, and it was led by a palliative care physician and an oncology registrar. And actually, it then became to be quite well known in some of the guidelines, so the British Thoracic Society guidelines, ASCO guidelines. The only study they quote in terms of is radiotherapy good for pain control in mesothelioma was this Systems 1 trial. And the ESTRO guidelines, same thing. So we had this impact. So all well and good, but as I've worked in on cancer oncology for 20 years, oncologists like to see if we can give more radiotherapy, see if that works better, which is obviously a reasonable thing to do. So the baton is very much handed over to Miranda and Anthony to do Systems 2. So this was the first study, was a single-arm trial, so everyone got the same thing. But what we wanted to do now is see if we gave patients more radiotherapy versus what we had given them in the previous trial, that potentially improved outcomes. What was it indeed better? So, in terms of our eligibility criteria for that study, we wanted patients with a histological or an MDT diagnosis of malignant pleural mesothelioma. They'd have a CT scan within 8 weeks of starting radiotherapy. We wanted, again, this is about trying to limit any other effects, no anti-cancer therapy 4 weeks before or 6 weeks after radiotherapy. So it's a 10-week window where we're trying to minimise other things changing. A pain score of greater than 4 out of 10 after their analgesia had been optimised. Reasonable life expectancy, well, reasonable, terrible life expectancy, but a life expectancy of 12 weeks for this population is in a trial is reasonable, I guess. And a performance rate of 0 to 2, so generally up and about and functioning well, to having some time sitting in a chair. So those were our eligibility criteria. One of the challenges with a study like this, I've seen this a lot, I've done this a lot, is that you do a small pilot study that works really well, and then you try and enlarge it to a bigger study across multiple sites. And what we did in the pilot study was a lot of control, but to get the bigger numbers we needed, we have to include lots more sites. So one of the challenges here is to try and get all the sites managing the patients the same way, what we call managing the fidelity of the intervention. And a key thing to that was analgesia optimization, trying to get everyone as good as we could get them before they went into the study, so that dramatic changes didn't occur in their analgesia during the study. So patients were screened, and at baseline they were randomised to either the control arm, which is what we'd used before, 20 grays and 5 fractions of radiotherapy, or what we call the treatment arm, or the experimental arm, which was 36 gray and 6, or 30 gray and 5. And the primary endpoint, so the time where we assessed whether or not that had made a difference, was at 5 weeks. And then we did some additional follow-ups at 9 weeks, and then at 6 months. So what we call our primary endpoint, if you like, our measure of success or failure, was that we wanted to take their worst pain score. So if they had a pain score, for example, of 6 out of 10, 10 being bad, we wanted to take it down by 2 points or more, so from 6 to a 4, or from 8 to a 6, or whatever. And we used a specific tool called the Brief Pain Inventory for this. It's a validated questionnaire. And we powered the study, so that means we designed the study to detect 20%, an absolute increase of 20% in proportion to the responders. So we worked out how big a study we need. I think it was 112 patients, or something like that. We did what we call secondary endpoints, so other aspects which we look at of interest. So is it toxic? We had to be open-minded that was this potential newer treatment actually more harmful? We looked to see how imaging changes, how the X-rays and the CT scans changed at 9 weeks. We wanted to see look at survival as well, and we wanted to look at quality of life. So pain thing, but quality of life, pain, if you like, is just a component of a quality of life assessment. So we wanted to look at quality of life as well at weeks 5 and week 9. So I'm just going to highlight just a few of the results today, because we're still analysing some of the results. So some of them will be coming in due course. So I remarked to Anthony Chalmers the other day, Kevin, that for a neuro-oncologist, I said it was pretty impressive to dabble in a pleural disease radiotherapy study. So Anthony did really exceptionally well, because this is, as you know, it's a rare disease across a lot of centres in the UK, and there were registered 122 patients, of which were randomised, approximately 50-50 to either the higher dose of radiotherapy or what we did in the previous study. And you can see here on this slide how many patients were evaluable at each of the different time points. And we use what's called an intention to treat analysis. That's where when you put patients in the study, you examine them all no matter what happened to them, if they drop out or whatever. And this is the first randomised trial of radiotherapy for mesothelioma pain that's been done. So it's a phenomenal feat to do this. In terms of some of the characteristics of the patients, they were quite well matched, and we used techniques to try and match patients to make sure we've got the same type of patients in the same groups, so there's not a bias between the groups. You can see here that these patients, the time from diagnosis was just about 9 months, 9-10 months. Most of these patients had a reasonably good performance status, and you can see the balance between epithelioid and sarcomatoid mesothelioma was very much equal between the two groups. And other sort of characteristics are relatively similar. It's important, again, in a study like this, looking at their pain. You don't want all the people with really, really bad pain in one group and all the people with less pain, for example, in another group. You want to try and get them as similar as we can. So in terms of what we called our primary endpoint, so did their worst pain, so how bad their pain gets over the course of a day, did it improve between the two groups at 5 weeks? And the answer was, from our current data, was it didn't make any difference. Not one treatment was better than the other. When you look at what we call a responder analysis, there was no real signals or anything that these patients were doing better or worse in one arm or the other. So the study, in terms of meeting its primary endpoint, so what we set out to do, it didn't meet that. What we also looked at was toxicity. Okay, so was potentially this new treatment worse? Well, when you do a study like this, you power it, you design the size of the study based on the main thing you want to measure. And when you look at other things, a lot of studies, certainly this one, it wasn't designed to see if it was more safe or not. But data don't lie, and you can see here the patients in the dose-escalated arm had a bit more acute toxicity in terms of dysphagia. So 5 patients in the dose-escalated arm, and you can see also in terms of vomiting a bit worse too. We were giving these people a higher dose of radiotherapy. It might be, understandable that they have a few more sort of acute side effects from that. But these were really quite small numbers. In terms of sort of what we call toxicity during follow-up, so not sort of in the initial phase, but afterwards, in terms of what we call radiation dermatitis, so sort of inflammation of the skin around the area where they had radiotherapy, it was quite a bit higher in the new arm, the thing we were testing, versus the standard arm. And interestingly, there was a bit more pain in the standard arm rather than the new arm we had. So, so far we're thinking this here didn't really make a massive improvement in pain, potentially even more side effects in the other arm. Now, if that is the case and that turns out to be the finding of the study, well, that's still really important, because we know, that we maybe shouldn't be doing this higher dose of treatment. And that's critical, because sometimes we do think that more is better, and sometimes less is better. But what we have found, however, and I use the same caveat, this was not designed to test survival, but those patients who got a higher dose of radiotherapy appeared to have a better survival than those patients in the standard arm. So the overall survival was 5.8 months, so just 6 months, give or take, versus 4.5 months, so an extra 6 weeks. Now, that reaches what we call statistical significance. So, that says it's more likely to have happened, not by chance. And if you can see, when we look at, 6 months survival and 12 months survival, the figures become even a bit more encouraging. So this was sort of overall, but if you look at a 6-month time point or a 12-month time point, the figures are more encouraging. Now, I'm not getting too excited about this final slide, which talks about a difference of 31 months versus 9 months, because we're still in the follow-up phase of the study. So we're still waiting to see if patients may pass away while they're on the study. But certainly there may be an improvement in survival at this point. Now, one of the things I've tried to press on you at the start of the talk is, when you do a study like this, when you're assessing an intervention, particularly a pain intervention, you want all other things that affect pain to not change. We want ideally, when someone goes into a study, if they're on morphine, they're on other nerve painkillers, we want all of them not to change. But it's very difficult in a study. You've got somebody who may have severe pain, and you say, I'm really sorry, you've got really bad pain, you can't take any more morphine because you're in our trial. Of course we don't do that, that would be unethical. But what we are doing just now, and we haven't looked at yet, is we are analysing it, but the data are not available, is to see what happened to the different analgesics or painkillers these patients were taking between the two different arms of the study. Because there's a possibility that patients, although there was no difference in outcomes, it may have been changes in analgesia between either of the arms may have impacted some of the outcomes. I think the other thing to mention is that we touched on this earlier, quality of life. In a study like this, pain is just one aspect. Our general feeling is that people, when they're in clinical trials, they do better, they feel better, I think, generally feel they're better looked after, and that's been my experience in research. So we are still looking at quality of life outcomes in this trial, and that's another really important thing that will come out of the data in the future. So in summary, this newer, higher dose seems to be well tolerated. There seems to be no improvement in pain, but we're currently undergoing additional analysis to really dissect that out. There's some evidence of improved survival, but we need to repeat that in 6 months. I don't expect the 31 months, 9 months to stand, but it's certainly quite encouraging that there might be a survival difference. And I say we're doing the pain and quality of life analysis as well, which I think will give in these trials, the devil is always in the detail. So we'll see what comes out of that. So I think, at the moment, what we can say, radiotherapy is certainly active, and it's got, a role in the management of mesothelioma. If I give an analgesic that basically works in 1 in 2 people, that's pretty good. So I think, there's a scope for this. The trick is really to work out which patients we should be giving it to, giving the right drug or the right dose of radiotherapy to the right person at the right time. So this is trial took so long that Miranda actually had a baby during it. So this is the trial team, and it's pleasure to present today. It's Kevin on behalf of everyone, and happy to take any questions from the audience.
No?
I've got some questions for some of the non-medics and non-health professionals. Do you have any questions about the mechanics of that? Because I tried to tone down the language of it, but we use a lot of jargon in medical profession, don't we?
Yeah.
And it was there's a lot in there.
I mean, when this was presented at BTOG, there was a bit of discussion about. You did a really good job of explaining the kind of need to balance the different variables, including the balancing of the characteristics of the two cohorts.
Yeah.
And the survival thing is the thing that you want to get excited about, don't you? Because we want to believe that giving radiotherapy at a higher dose, maybe that signal is real, and maybe that means that maybe doing something slightly differently might give us a new radical option. I guess the balancing in the standard arm, I think there were something like double the number of stage 4 patients.
Yeah, exactly.
In
a small study.
38% versus 20%. And, they're, as you say, I think it's really important to wait and see with that. But, I mean, also, I don't know what the nurses, we've got the nurse specialists here who I think pain is still the hardest thing, actually. And I don't think we've got a good way of, because often the question we have in the MDT is, should we send this person for radiotherapy, and how do you make that decision? Because there's also cordotomy theoretically on the table, and you know all about cordotomy. So I don't know if the nurses want to comment on that, or maybe you could comment, Barry, on how, as a palliative care physician who might refer patients for cordotomy, how you might decide.
Yeah, I think it's so in theory, cordotomy can work really well. We did a study published a couple of years ago, looked at this national cordotomy register, and what we showed in that was that cordotomy worked in like 85% of people, but most of them died within a month. So I think if you've got somebody there's a really good cordotomy service in Glasgow. We don't have that in Edinburgh, and we have to refer to Glasgow. I think if you get somebody with mesothelioma and pleurotic chest wall pain due to meso, then my advice is don't spend, weeks and weeks changing drugs and analgesics. Just, get them referred to the specialist palliative care team ASAP, and press on that palliative care team. I think this patient should get a cordotomy, because a lot of certainly in Glasgow the beats are obviously very good and things, but some teams still think, oh, we have to try this first, we have to try that first, we have to try that first. Well, no, we don't. If you've got a really good treatment that we know works, which we do, then refer for it, I would say.
I don't know if Carolyn or Susan or anybody's got a comment. I mean, my impression is every time we think about that, we send them, and either they're not suitable in some way or they're not fit enough, or it quite often never materialises as an option.
To lie flat and not move for, I think it's an hour that they want you to be able to do that. So for a patient that's struggling with pain, a lot of them just can't manage. And then there's the balance of you've got enough time left to benefit versus not too much time that you get refills.
Yeah.
I see Dr. O'Rourke has sneaked in the back.
I think I know what the results show. So I'm going to come in here with the biased oncological comment on the how do you treat pain in mesothelioma. It's the same principle I would apply to how do you treat pain in every tumour, which is if you can shrink the tumour, that's going to help the pain. And albeit mesothelioma has always been a real challenge for us because it is diffuse and it's hard to pinpoint and it's not a single spot that you're aiming for. What we tried to do with the systems trial was to localise where the source of the pain was as best we could. And I think the advantage of radiotherapy is that you are therefore targeting the tumour. So you are hoping that not only will you improve the pain, but part of the reason you're improving the pain is that you're actually shrinking the tumour, which is why I'm always trying to shrink the tumour if you can. Good pain control and medical management of pain control and cordotomy have all got potential in there. But if there is a way of treating this that treats the tumour, then get the tumour. So yeah, very biased, very oncological, but there you go.
And I think it's I mentioned at the start, Noel, and for the Systems 1 study, we had one of the benefits of doing a single arm, essentially a single centre study, was that all these patients had reviewed them from a pain control point of view, and UNIC planned them together. Right, so they were almost as good as we could get them before the study started. And then when you roll it out to a multi-centre trial where they maybe don't have that degree of fidelity, it becomes more tricky. I mean, I think that if you get somebody, with mesothelioma, we'd one through in our hospice last week in Edinburgh who we referred through, and 3 weeks before they got seen, and then they were just, Selena, it's exactly what you said, they were too sick. I would be thinking about referring them, at point of have they got measles, have they got pain, at least get them in the system.
But it does seem all the study has kind of shown that it's it seems to be a late event. The time from radiotherapy intervention systems 1 and 2 to death and cordotomy in our experience, the patients they only have a very short period of time to go.
Yeah, and the message in that is they need to get referred sooner. You don't need, you should. Until these people are wasting away from systemic effects of disease, really struggling, having problems with pain control, even with optimal input in terms of their medication. The point is that pain is a feature quite often early on, and you shouldn't have to wait until people are in a really bad way before you think of doing something about it. Yeah, and that would be my message.
I agree.
Yeah, I just wanted to say, you mentioned about optimising oral analgesia and making sure their pain control is as good as it can be. I think as a CNS, it's quite hard to know when that point is. When do you stop increasing oral analgesia and popping? But I think that's the beauty of the NDT. It's quite an open NDT that it's not just for diagnostic purposes, and so it's quite easy for us to add someone on to have that discussion. And often we have palliative care at the NDT too, which is amazing. And I guess, it was just to sort of...
There's not a magic, I can't sort of say, here's the list of, here's the standard thing you would do, but as I said earlier, I think in terms of the people with pain I manage, mesos and the sort of cancer, invading the pelvic pains are the two worst pain subtypes I deal with. And to be on a strong opioid, usually an adjuvant in forms of something like pregabalin and a topical lidocaine patch are three reasonable things to start. The challenge we have is when you do a trial, you can't be too prescriptive. You have to have a sort of basic pragmatic approach. But I think these are sort of reasonable things you would expect somebody to be on. But I've seen patients who are months and months, and then, all right, we'll try this type of morphine, we'll try this type of opioid and our type of opioid, and then we'll try a pump, and then we'll try methadone or ketamine, but yet we know cordotomy works. So, the message that I say, and same as the team in the Beats and say, is if they're on, if you start them on an opioid and they've still got pain, get them referred. And then, as I would, my call to arms would be that if you've got mesothelioma, you've got pain, be considered for at least think about a cordotomy. And sometimes it needs to be, the CNS is telling the palliative care teams, no, I want you to refer to a cordotomy, because then it's very difficult for them to say no.
Yeah, I mean, our cordotomy service, the respiratory team can refer to as well now. It's not just palliative care. So, and just if it's okay, sorry, just to link your question you had asked earlier about quality of life and should we be looking at kind of patient experience, and that's something as CNSs we've discussed a lot, and it's something that we want to do. And I guess looking at pain control now versus pain control pre-network might be something that ties into that quite well.
Absolutely, really good to do that. We've done a few sort of qualitative studies, and we've looked at people who've taken part in clinical trials as well. And what they say is, it doesn't matter if they get a benefit; they like taking part in trials. They feel benefit from it. So that's something you want to do. I'm happy to would support you doing that, because I think that's really, really important. And I think to do studies, these studies are all well and good, but I'm going towards now more mixed methods type studies. So we do an RCT, but in do that. And along with that, we do an embedded qualitative study. We're actually saying to the patients in the study, how was this? How did you find it? Was that good? Okay, the new treatment's good, but how did you feel about having, some severe sort of skin reactions? Or, I think that's really key. And you'll see more and more trials coming out with that mixed methods approach.